This is a class for your early clinical exposure. So this can be done in 3 ways. One exposure can be made in the classroom, another classroom settings, and another kind of exposure will be in the clinical settings, means in hospitals, and also in the community. So we will be taking you to, now there will be classes through the classroom settings, then after that to the clinic, and then to the community. So in classroom settings, what happens? We present a case, suppose anemia. Then about anemia, the patient can be brought here, and you will see the case, and you will see the prominent changes in his body. You will notice, you will be observing it, and one teacher or some other persons will be there. They will discuss about this case. Then how the history is taken, what are the signs, symptoms, what are the investigations made, okay, what is the provisional diagnosis and the management. Okay, so this diagnosis, suppose it is anemia, then this will be related to physiology. This will be related to physiology. So what are the causes, what are the physiological changes it made. So this will be linked to my subject, to physiology. In biochemistry classes, the case will be related to they will make it related to the biochemistry, and similarly to anatomy. Okay, so here we will relate the case with physiology. Okay, so that one, since the other teachers will be coming, so, and the case is based on anemia, but you don't have, I couldn't give you the idea of anemia. So I will today, right now, I will give you an overview about the anemia. Understood? So then in the later half, you will be in a better way to understand the anemia, what is there going on. So the teachers may ask you some questions. So since you will be having the knowledge about anemia, so you try to understand, try to follow what I am telling, what I am showing. Okay. So this is anemia. Anemia means means no. And means no, without. Mia means blood. Means it's a condition without blood. So without blood means less blood. Okay. So the term anemia came from that only. See, anemic blood is having less RBCs, where the normal blood is having more RBCs. These are the normal values. If the values come, depending on age and sex, the values come below this level, then this is not normal, abnormal value, okay? And this is what is anemia. So in anemia what happens, some new term will come, I will explain. RBC count becomes less. Since RBC value becomes less, hemoglobin value will also be coming down, and the hematocrit. I told what is what is hematocrit. If you take 100 ml of blood and rotate it in centrifuge machine, then the cells will be separated out, and see out of 100 ml, how much, what is the content of this cell. This is the hematocrit value. So usually it is how much, 40, 45 like that. So this is the hematocrit value, or also we call it PCV, packed cell volume. Okay, you understand this? Okay. So anemia is the blood disorder characterized by what? Red blood cells, hemoglobin content, packed cell volume. Generally there is reduction in RBC count, hemoglobin level and PCV. Automatically this has to happen. And why it happens? Because of loss of blood, because of lack of production, because of destruction. So these are the main reasons. What are the three main reasons? So for during hemorrhage, a lot of blood is coming out from body, so it may cause. And next is what? Less production, more destruction. Okay? And pathophysiology. What happens if hemoglobin level, RBC level comes down? What will happen to the body? It will be unable, the blood will be unable to carry sufficient oxygen to the tissues. Means there will be hypoxia. And this hypoxia in the tissues will create some changes in the body, in the cells, in the tissues, in the body. Okay. So there will be pallor. There will be pallor, means pale conjunctiva, pale skin, brittle nails. So a lot of changes, sign symptoms will be appearing. So this way, this anemia creates a lot of sign symptoms. What are these symptoms? What are these symptoms? Easy fatigue. Why fatigue? Why loss of energy? Because oxygen is not, sufficient oxygen is not coming. Lack of, there will be, energy, the required energy will be less. So, muscles will be unable to contract. So, there will be lethargy. So, lethargy will be there, loss of energy, fatigue will be there. Usually there will be rapid heart movement. Sometimes you will feel throbbing of heart. Okay, and shortness of breath means dyspnea. Difficulty in breathing, call it dyspnea. So you may face dyspnea. Okay, so this is clear in emphysematous patients, asthma patients. They feel dyspnea and sufficient oxygen they are not getting. For that they are trying to take more oxygen, more air, but their problem is in their airways. So they are feeling hypoxia. So what will happen? There will be stimulation for erythropoiesis. So you will try to generate more hemoglobin, more RBCs to collect oxygen from the lung. So there will be dizziness, reeling of head. There may be pale skin, as I said, pale conjunctiva, leg cramps, and insomnia. Okay, insomnia means lack of sleep. Bounding pulse, as I said, palpitation. Palpitation, so what happens? My heart is throbbing. Sometimes it appears some beats are escaping. This sort of feeling may come. And tachycardia means sustained heart rate, increased heart rate which is sustained. If you start exercising, your heart rate will be increased, more than 100. But when you take rest, it will be coming down. If it is not, the increased heart rate doesn't come down, then we call it tachycardia. So there will be headache, okay? Pre-syncope. Pre-syncope means sometimes what happens, sitting for long period, after sudden taking erect posture, there is reeling of head, as if I am going to faint. So this is pre-syncope. Headache, cognitive impairment. Cognitive impairment means unable to concentrate, unable to take decision, unable to memorize. It happens with me. Unable to memorize. So this is called cognitive impairment. Dizziness, I told, apathy. Apathy means, what does anybody tell? What is apathy? loss of or lack of, when there is lack of energy, we cannot take any endeavor. So we become lethargic. So it is called, means there is no energy, no positive endeavor you can take. Signs of iron deficiency anemia. This is called koilonychia. Koilonychia. What is this? See, our nail is curved like this. But in such case, iron deficiency anemia is maybe flat or curved downward, spoon shape. So with those who are suffering for long in iron deficiency, they will show this. There will be, usually our tongue is rough because of presence of papilla, taste buds. But because of this anemia, long-standing anemia, it may become smooth, red. These are because of atrophy of the papilla. And dysphagia. Dysphagia means difficulty in swallowing. Because in the esophagus, there are some waves are formed. And these waves are preventing food to get in. Okay, this is called dysphagia. Glossitis, inflammation of the tongue, glossitis, and angular stomatitis at the corner of the lips. So angular stomatitis, Plummer-Vinson. Plummer-Vinson is a syndrome created by iron deficiency anemia and so esophageal waves and dysphagia. So this together is called Plummer-Vinson. See, these are the symptoms of anemia. What are these? Eyes will be yellowing, pale, and the skin paleness, cold. Skin will be cold, and there is in respiration there will be shortness of breath, and muscle will become weak. Intestinal, the stool color will be changed, and central fatigue, dizziness, and in extreme case fainting will be there, and blood vessels, there will be low blood pressure and heart palpitation. These are already I talked to you, and there will be splenomegaly also. Please. You are?
I'm Dr. Abhishek.
Okay, please sit. So these are the symptoms of anemia. Actually, our classes, this session is on anemia.
Yes, sir.
So I am taking the hematology classes, but they don't know anything about anemia. Okay. That's why I am giving them an overview of anemia. So after that, we will be studying.
Okay, for sure.
So we can classify. Sir is expert in hematology. Okay, specialist in hematology. So we can classify anemia in three ways. One is clinically, another is morphologically, another is etiologically. Etiology, what is the reason, cause behind? So based on the causes, we are classifying etiologically. And morphologically, hemoglobin means size. In different anemia, size of the RBCs are changes. Sometimes it remains normal size. Sometimes the size may be reduced. We call it microcytic. When the size is increased, these are not matured. During developmental stage, they are coming out. So these are called macrocytes. So again, we can classify it depending on the color. Color means hemoglobin. So this will produce, if I say one RBC is macrocytic hypochromic. Size is big, but it is producing less color, means there is relatively less hemoglobin. Okay, so this way we will classify later, morphologically. Now clinical classification, see, is that value okay?
Yes, sir.
So we clinically classify into mild, moderate and severe. So remember this values. When it is below 12 and 9 to 12, we classify it as mild. Then from 6 to 9, it is classified as moderate, and below 6 is severe. So this is clinical classification. Now the etiological classification, we made etiologically 5 classes. What are these? One is hemorrhagic anemia because of hemorrhage. It may be 2 types, acute, chronic. I will come to later. So then it may be hemolytic for some reason, external reason or from internal reason. After releasing into the blood circulation, they are hemolyzed before their lifespan is over. So they are hemolyzed. Okay, so it becomes non-functional, destroyed. And another is nutritional deficiency anemia. We know iron deficiency anemia. We take iron through our diets. So if there is lack of iron supply, so we may face iron deficiency anemia. What are the reasons will be discussed later. And there is other nutrition, vitamin B12. Vitamin B12, it may cause another anemia. We call it pernicious anemia. Okay, how this pernicious anemia develops, we'll study. Then another anemia, nutrition anemia is there. This is due to lack of folic acid. Megaloblastic anemia. Yeah, this is megaloblastic anemia because of lack of folic acid. Then we come into aplastic anemia. What happens in aplastic anemia? The bone marrows, they are disordered by some means. So because of that, anemia may develop proper way. There is no erythropoiesis, will not be happening. So there will be anemia. And anemia of chronic diseases. Anemia of chronic diseases like tuberculosis, like joint rheumatoid arthritis. Okay, so this sort of chronic diseases may also produce anemia. So hemorrhagic anemia, as we said, it may be of 2 types. Acute. Suppose there is an injury, so a lot of blood will be coming out. As a result, some cellular elements will also be coming out. Means there will be reduction of RBCs, means hemoglobin, means immediately what happens in our body to sustain our life, it draws fluid. It draws fluid from the extracellular fluid and make up the plasma volume. But because of entering of additional fluid, so blood will be diluted, so there will be, when we will be analyzing it, so it will produce low RBC content, low WBC content, low PCB. Okay. And this is the result of acute hemorrhage. But when acute hemorrhage is produced, lack of hemoglobin, lack of RBC, so we will face hypoxia. This hypoxia causes stimulation of erythropoiesis, means there will be secretion of erythropoietin by the sensus cells. They feel there is hypoxia, there is lack of oxygen. So these sensus cells present in kidney, I told previous day, there are these sensus cells lies in kidney, also in liver. Okay, and they will produce erythropoietin. Now erythropoietin will act on bone marrows, cell division, maturation, differentiation. So there will be a lot again. Since there is increased erythropoiesis, so blood levels of hemoglobin, blood levels of erythrocytes will be raised. But see, the case is different, little bit different in chronic hemorrhage. Chronic hemorrhage means there is continuous release of, in small amounts, there is continuous release of blood. For example, somebody is having peptic ulcer. So from there, some blood is coming out. Okay, it may happen in piles, those who are having piles. So some blood is coming out, means when losing some blood, losing some iron, losing some blood cells, so it may produce anemia. The adolescent women till their menopausal age, so they menstruate every month. So through menstruation, they are also losing some amount of blood, and this may also cause anemia. So these are the chronic hemorrhages. Okay, and hemophilia. What is hemophilia? What is hemophilia? Can you name one coagulation disorder? Coagulation, because of there are a lot of coagulation factors in our body.
Fibrinogen in plasma.
No. When blood vessel is injured, there is continuous, delayed coagulation. So there will be prolonged hemorrhage for prolonged period. Okay, we'll discuss in coagulation class. So these are the conditions: purpura, hemophilia, menorrhagia. So these are the conditions where chronic hemorrhage takes place. Hemolytic anemia. When the blood cells are released, it may be normal, it may be abnormal. See, these normal blood cells, they may face some awkward environment around it, and this environment can damage the cells, cause hemolysis. They can damage or destroy the red cells. So there are external factors, and some erythrocytes are having some faulty hemoglobin or faulty globulin molecule in them. So because of presence of these faulty things generated in the bone marrow, so they will be destroyed. They cannot survive for long, for 140 days. Okay, so before that they will be destroyed for some reason. I will explain. So two factors are there: external factors, internal factors. Means factors within the RBC. External factors from outside. So let's see what are the extrinsic factors. So here, destruction of RBC by external factors such as antibodies, chemicals, and drugs. Okay, so common diseases, there is hemolytic anemia, in liver failure, renal disorder, hypersplenism, means hyperactivity of the spleen, and burns, infections like hepatitis, malaria is common, malaria, septicemia, and some drugs used for malaria treatment, for this penicillin, sulfur drugs. This may cause as external factor and damage the RBCs. The intrinsic hemolytic anemia, see here, destruction of RBC because of the defective RBC. So defects means unhealthy RBC which are short-lived and destroyed soon. And what are these? Two varieties are there. Sickle cell anemia. In our last class we discussed sickle cell anemia. What happens in sickle cell anemia? Can anybody tell?
It is a Mendelian disorder.
Yes.
Beta polypeptide chain gets there is means six position.
Yes. There is, what is the amino acid? Glutamic acid. It is replaced by valine. Okay. So this globin, because of It is not normal, beta chain. So what will happen? This becomes crystallized. This becomes crystallized and binds with the membrane. So then only it also elongates, and because of this, the shape of the RBC is changed to the shape of, it takes the shape of a sickle. This is called sickling, and this type of sickling cells, when they travel along the blood vessels, they come and cause obstruction, and they may also be hemolyzed. Is that okay? Okay. And this is sickle cell anemia, and another is thalassemia. What happens in thalassemia? Problem in beta chain. Problem in beta chain, and also beta chain of beta polypeptide. We have two beta chains, two alpha chains. We know alpha chain contains how many amino acids? 141 amino acids. Beta chains contains 146 amino acids. So if there may be problem in alpha chains, so this may cause thalassemia. So thalassemia, alpha thalassemia, and when the problem is in beta chain, we call it beta thalassemia. It is an inherited disease. It is inherited disease. How it is inherited? When both parents. So one type of thalassemia is alpha thalassemia, another is beta thalassemia. Alpha thalassemia is very less, very less, but beta thalassemia is common. Beta thalassemia is again are of two types. Are of two types. One is major, another is minor. Major means here both parents, since it is inherited, the both parents are contributing faulty gene. As a result, faulty beta chain is produced. But in case of minor, only one parent is having faulty gene and producing faulty beta chain. Okay? These cells, faulty RBCs having faulty chains, they are also hemolyzed in the blood. Thalassemia, alpha thalassemia, rare, beta thalassemia, two types, beta 1, beta 2, beta major and minor. Okay, now hemolytic anemia we discussed. Now we will discuss about nutritional deficiency anemia. Yesterday in our last class we discussed about the role of gastric mucosa. So in gastric mucosa, gastric glands, if you see the gastric gland, you will find there are a lot of cells, secretory cells. One cell type is parietal cells, also called oxyntic cells. They produce hydrochloric acid. These cells also produce another important thing, intrinsic factor. This is very much needed for absorption of vitamin B12. You take suppose we have a sufficient amount of vitamin B12. Without help of this intrinsic factor, it cannot be absorbed. It is a must. Which one is must? The intrinsic factor is must. What does it do? The vitamin B12 combines with intrinsic factor. Now it will travel, nobody is going to disturb it. So it will pass through the GI tract and up to the ileum. From where there it will release this vitamin B12. Now it will be absorbed. Then after absorption by the enterocytes, it will enter in blood, that will be carried by some carrier and it will go to the liver or muscle for storage. And again this will be transferred to the bone marrows for erythropoiesis. Now what is the need of vitamin B12 in erythropoiesis? For erythropoiesis, lot of RBCs has to be produced. So it needs cell division. And for cell division, without the help of DNA, it is not possible. Is it possible? So their DNA is playing a vital role, and this DNA is formed from with the help of the necessary vitamin B12 is necessary, and another vitamin is also essential, that is folic acid. Okay, so see, if there is no intrinsic factor, vitamin B12 will not be absorbed. As a result, because of deficiency of the vitamin B12, there will be anemia. There will be anemia. The cells will be, when they are released, they will be megaloblastic. No? They will be macrocytic. They will be macrocytic. So cells are not normal in size, bigger in size. And this anemia, because of lack can be because of absence of either you are taking less vitamin B12, or your stomach wall there is problem, there is ulceration, or what happens, some antibodies, our immune system produces some antibodies. They destroy the peptic cells. These oxygenate cells, parietal cells. As a result, this will not produce hydrochloric acid, it will not produce ICF, intrinsic factor, so there will be no absorption of vitamin B12. Instead, you are taking, so it may be because of lack of intrinsic factor, it may be because of, sometimes what happens, parietal cell is working, but it is releasing intrinsic factor. Now another antibody produced by our immune system, it is not a normal phenomena. So it binds with this antibody binds with the intrinsic factor. So intrinsic factor now unable to transport the vitamin B12. So this also cause pernicious anemia. This is okay? Okay. And there is, because of deficiency of folic acid, so there is another type of anemia we call megaloblastic anemia. Mega means big, means macrocytic anemia. Okay, so it is also, these are all nutritional deficiency. And even protein deficit. So proteins are needed, we take protein. Proteins are very complex substance, so it cannot be absorbed directly from the intestine. So what it undergoes? Simplification. Means it undergoes digestion, converted into amino acids. Now these amino acids are absorbed from the intestinal lumen into the blood. Now these amino acids are taken up by the cells, tissues. Who need it? For the synthesis of different kind of proteins, new proteins, say enzymes, some hormones. Okay, so rhodopsin, iodopsin, contractile proteins. So lot of functions are there for proteins. So if you take less protein, so less amino acids will be available. So this, because of this, less globin will be produced. So it will also cause anemia, protein deficiency anemia. Iron deficiency, it is also a nutritional constituent. Say iron deficiency will cause microcytic hypochromic anemia. Okay, it happens also during chronic hemorrhage. Microcytic hypochromic anemia. Causes of iron deficiency are loss of blood, as we have seen, loss of blood, also decreased intake of iron, and poor absorption of iron. See, for iron absorption, so many things are required. It has to be absorbed in the ferrous state. So, vitamin C also playing important part. So with the if these are properly absorbed, then there will not be anemia. If any disturbance is there, you are taking less, properly not absorbed, properly not carried to the organs where blood will be formed, then this deficiency, this iron deficiency anemia will develop. Because moreover, iron is required in excess amount, more than normal in amount. So, what is the normal amount? 30 milligram, no? Iron daily?
Daily intake.
Huh?
40 to 50.
42. Daily we want about 40, but requirement for females is more because of their daily loss, their monthly loss of blood. Okay. So during pregnancy, demand is more. So these conditions increases iron demand. So if it is not properly fulfilled, then the anemia will be developed. What are the features? Nail will become boat shaped, and hair will become brittle, and tongue smooth, and dysphagia. What I told, what is dysphagia? Difficulty in swallowing because of waves, esophageal waves. Plummer, what syndrome? Plummer-Vinson syndrome. It will produce Plummer-Vinson syndrome. Protein deficiency anemia, in that case it is the RBCs will be macrocytic, hypochromic. Pernicious anemia, lack of vitamin B12. Cause may be different, as I said. Okay, cause may be different. So in this case, the cells will become macrocytic and normochromic. Megaloblastic anemia, this is because of folic acid deficiency. Folic acid also required for DNA synthesis. It has to be converted, folic acid has to be converted into folinic acid, and there are some means by which it participates in DNA synthesis. And aplastic anemia, as I said, the bone marrow, disorder of the red bone marrow. So this disorder may be influenced by X-rays, gamma rays, some toxic drugs, okay, some chemicals. These are some diseases, tuberculosis, viral infections like hepatitis, HIV. So they may cause aplastic anemia, means damage the bone marrow. Anemia in chronic diseases. What are the diseases? Rheumatoid arthritis, tuberculosis, chronic renal failure. So they may cause anemia of chronic diseases. So how many classes of anemia are etiologically? 5. What are these? Hemorrhagic, hemolytic. Hemolytic, then nutritional deficiency, aplastic. Fine. So now we will discuss about morphological classifications. Any other classification? This is okay. What are these? Microcytic, hypochromic anemia, macrocytic, hyperchromic. It is very, this condition is hyperchromic.
Mostly some macrocytic.
Mostly macrocytic. And normocytic. Okay, these are the 3 classifications, and morphological classification is based on we are not measuring the diameter of RBC. Under microscope, we are not measuring. So, how these are measured? These are measured from hematological indices. Actually, I didn't. These hematological indices, what are the different hematological? This class was not there. So, they don't have this idea. So, from these two indices, one is MCV, mean corpuscular volume, the average size of the RBCs. It is derived from, I'll give you some one equation, and how much hemoglobin is there, it is estimated from MCSC, mean corpuscular hemoglobin concentration, and the other one is mean corpuscular volume. From this derived, I will get some number, and it is normal range. If it is more than say in case of MCB, it is 80 or 96.
78 to 94.
90, somewhere it is 96, somewhere it is 90, it is okay, somewhere it is 100. So that is the upper limit. It is goes beyond that, that is macrocytic. If it is less than normal, then it is microcytic. Average size of the RBCs. And the content is estimated from MCSC, average content. So it is given in picogram, and the range is very small array, 33, 32, 34 like that. Okay. This equation is okay. So how we derive? So that for MCB we need hematocrit. You will be doing it practically. You will be doing hematocrit. We will be finding it out. What is the particular blood sample will be given? You will find what is the hematocrit value. Then you will be measuring also, estimating the RBC count. So you divide hematocrit and multiply it by 10, then divide it by RBC count, then you will get a range, that is a value which is in between, should be in between 78 to 96 feckoliter. Unit is feckoliter. Okay. And for MCSC, hemoglobin percent divided by PCB, PCB means hematocrit, into 100. Normal range 33 to 37. Is that okay, this range? Okay. And MCS not needed now. See, morphological classification, how we classify? See, here microcytic, MCB less than 80, normocytic 80 to 100, it is given a wider range, no? This is my value, 80 to 100. It should be actually 100, it is 96. Okay, and more than 96 means it is macrocytic. So these are the values by which you can, when you get your values, then you will be able to understand whether my RBCs are normocytic or macrocytic or microcytic. Okay. Morphological classification. So with normocytic, macrocytic, and at the top right hand side that is normochromic, hypochromic. What are the conditions? See, the red cells are normocytic, normochromic in A, B, C, D cases. A, B for after acute hemorrhage, all hemolytic anemia except thalassemia, aplastic anemia, and in such cases MCSC is normal, MCB is normal. Okay, and hypochromic anemia, example of normocytic hypochromic anemia is after chronic hemorrhage, we get it. And macrocytic, all megaloblastic anemias, all those are say vitamin deficiency anemias, vitamin B12, that is pernicious anemia, folic acid, because of folic acid, that is megaloblastic anemia. These are the example of this. They are having normal MCSC, high MCB. Okay, and macrocytic hypochromic, example, secondary to liver disease, iron deficiency, thalassemia. They are having low MCSC, low MCB. And microcytic, normochromic, example are chronic infections. Okay, and hyperchromic, microcytic examples are iron deficiency anemia, thalassemia. You learn this by heart. The causes of microcytic anemia, this is iron deficiency anemia, thalassemia, anemia because of chronic diseases. This is microcytic hyperchromic anemia, and see the difference. This is pneumocyte, this is macrocytic. Causes of macrocytic anemia, these are the causes. Megaloblastic anemia, pernicious anemia, post-splenectomy, alcoholism, removal of spleen is called splenectomy. Okay, some drugs. So these are the causes of pneumocytic normochromic anemia. Actually, I have very little time because another session is going to start. So my intention was to give you an overview regarding anemia. So now, when he will be delivering his lecture, you will be able to follow. Okay.